This week we're going to talk about triage. It's going to be a pretty short lecture. I just want to recap Beecham and Childress' remarks about triage and then look at two different examples to clarify what is at stake when we move from triage within an emergency room to like a larger scale natural disaster pandemic triage situation. And then look at Petrini's article. Hopefully you remember the idea of triage is sorting patients based on their need. So it's an issue of distributive justice insofar as there's limited number of resources and how do we ensure that we are fairly distributing them. Beecham and Childress give us a couple of notes here that I just wanted to remind you of, which is the first one is that usually triage rests on calculations of medical utility rather than social utility. And we'll see that here play out in the emergency room case in a second. But that's not always the case. I think Beecham and Childress are thinking within a hospital setting like an emergency room, and that's why they give this argument here. They also go on to say that it's legitimate to invoke medical utility, followed by this chance or queuing for scarce resources when medical utility is roughly equal for eligible patients. So this is a situation in which maybe chance or lotteries can be implemented to ensure that people have fair access rather than just people who are part of some privileged group, say people who can afford resources or can afford to pay more for them can have access to them and other people cannot. The idea here is that maybe lotteries or chance could play a role here in mitigating that type of discrimination. Then they also talk about how it's important to include the public in setting these allocation criteria. And I think that's a really important point that I wanted to bring back up once we get to the pandemic triage example. Let's begin with an emergency room situation. So I'm sure that most of you are familiar with what happens in emergency rooms, right? A number of people will walk into them with any range of injuries. So in this situation, let's imagine you overhear people talking. One person says that I stubbed my toe. Another person says I cut myself. And a third person says I've been shot. Who ultimately gets care first? Well, in an emergency room, there's a prioritization by who has the greatest injury. So if you say you've been shot, doesn't matter what order people came in, the person with the most serious injury gets seen first. And then it works down. And so imagine that the next person who goes back after they attend to the person who was shot is the person who experienced a cut. And then before this person who stubbed their toe can get back to see a physician or a healthcare provider, there's somebody else who comes in who claims to have chest pains, and guess what? They go before this person who stubbed their toe. So even if this person who stubbed their toe gets there first, all of these other people will get treated before them. Why? Because in this situation, medical utility is maximized based on who is within the emergency room at a given time. And it seems like when we are shown these different rules of triage, so again, this is a sorting mechanism. We make a decision about who receives care based on the severity of their injury and the fact that the people with the most pressing injury gets care first. That's a case in which we're trying to maximize this medical utility, which is trying to alleviate medical harms for individuals first. So that's what happens at an emergency room. As triage scales up, it seems like our considerations change because we're no longer dealing with just people who are filtering into an emergency room. Instead, you have a number of different vulnerable groups who are at risk here. And so triaging might have to be done instead of on an individual basis, but on a group basis. So imagine here a pandemic is happening and we have our healthcare workers who are operating in our hospital. Then we also might have the elderly who are susceptible to the disease. Another group might be the immunocompromised who are susceptible to this disease. And then if you remember, we also have these essential workers of people who ensure that supplies are getting from one place to another. All of these different groups are going to be affected, and we can start to triage based on different conditions. So like, should different healthcare resources be allocated to the elderly first, or the immunocompromised, or should healthcare workers get them first so then they can ultimately provide assistance to everybody else? What about essential workers to make sure that everything keeps flowing? But you see now, when we're making decisions based on groups, we are no longer just making these decisions on the basis of medical utility, even though that might be a factor that's going into this. We can also think about fair innings. So if you remember from our previous discussion, fair innings is the idea that since people who are more advanced in age have had their opportunity, it seems like we should invest resources in younger people. And then we also had the quality of life. We could have quality adjusted life years. This was another way in which it's said that resources should go to younger people because they are going to have a higher quality of life if we devote the resources there. Both these fair innings and quality adjusted life years are sort of discriminatory. Well, they're not sort of, they are discriminatory against elderly people. And so it raises a number of concerns there, but that's one of the basis for making these judgments. Social utility, so if we're trying to allocate resources to healthcare workers and essential workers to ensure that that these networks of distribution stay open, that could be social utility rather than medical utility. And then we also have the concern about protection against discrimination. What about people who are in positions, especially think about essential workers? Usually essential workers are people who can't afford to not miss work, and they are also the ones who are more likely to have subpar insurance or subpar coverage, and so are they put at harm or put in harm's way in such a capacity that is obviously discriminatory against that group over other groups. So now, instead of just operating within an emergency room, if we start looking more large scale, our concerns seem to broaden out. And so that's what I want to focus on here in the Petrini article, is about how the emergency room triage and larger scale natural disaster pandemic triage will look different and our moral considerations will shift. Petrini makes this distinction between ordinary triage and disaster triage. So ordinary triage is like the emergency room triage, in which we are presented with a relatively small number of people, and we are trying to make decisions about the severity of their injury, and these are typically geared towards medical utility judgments and trying to ensure that ultimately we maximize medical utility. So if somebody can wait, then they wait for however long until the sort of queue goes in the order of most severe to least severe. And then in disaster triage, this is where things become more complex and different considerations will ultimately be in play. So in disaster triage, you can have the utilitarian calculus of we're trying to maximize some utility, whether it be social utility, medical utility, but at the same time we have these egalitarian concerns as well. So hopefully you remember egalitarianism is about fair distribution. And so fair distribution of harms in these circumstances would look something like ensuring that there isn't discrimination. So people who are forced to work during these, say, during a pandemic or during a natural disaster, or imagine if a natural disaster were to hit a low-income area where there are less sort of guardrails against the intensification of the natural disaster, those people would be put at extreme risk or at higher risk than other populations. And so now there is an element of egalitarian fair opportunity, ensuring that there is no discrimination on a basis that is not morally acceptable, And so disaster triage, why I like this concept is because it really does show how the concerns will change as the magnitude of the triage event grows. So the other sort of concept that gets brought up here, I guess there are two different concepts. So the first one is the precautionary principle. We've sort of hinted at this before. So the precautionary principle is when we try to hedge against the worst outcome. So triage is an action that is necessary to address public health risks, and it stems from a pursuit of solidarity. It's better to ultimately err on the side of caution when the severity of a situation is unknown. So think about quarantine rules for this, right? If we're not confident that the disease is transmissible, or we are unsure how long the disease is transmissible, then we might put people in quarantine for a longer period of time just to be safe. And so this would be the precautionary principle in practice. We are being extra cautious because we don't have a sufficient amount of information at our disposal at the current time. And as more information becomes available, then we can revise. But it's better to err on the side of caution rather than just try to make judgments based off of what we think ordinary cases would be like. So precautionary principle is a pretty common principle that is employed in these larger scale natural disaster contexts, especially in the arena of environmental ethics, which is, again, more my focus. That's where I come across the precautionary principle about questions about how we ultimately tailor management to different areas. And even though we're not exactly sure how the management is going to affect the surroundings, the area or the management site, ultimately it's best to err on the side of caution. That's the precautionary principle in environmental ethics in a management setting. And so that's why I wanted to bring it up here, because it's one that you will find in a number of different ethical settings, and it's one that applies not just in triage situations, but also in just general medicine as well. If you're not sure how a patient would respond to a certain treatment, then maybe it's best to err on the side of caution rather than be too cavalier with your practices. That's just one concept. I'm not trying to tell you that you always have to err on the side of caution, although I'm convinced that that's probably the better approach, but it's just part of the ethical discussion here. So if you ever see precautionary principle, that's what we're talking about. This having to operate without complete information or complete knowledge. How is it better to hedge our decisions? Is it better to err on the side of caution or just do what we think is right? That's precautionary principle says it's better to err on the side of caution. All right, sorry, I hammered that home a little bit too much. But the other principle here that Petrini brings up, which is the basis of the conclusion here, is this principle of solidarity, which is a concern for the worst off or the disposition to care for the weakest members of the community. And the idea here is that the principle of solidarity is motivating our triage, our interpretation of what makes triage right or wrong. How about that? Because most cases of triage, we think that it's appropriate to employ triage practices because in the general circumstances, we think that it's best to take care of those who are worst off first and then work the other way. They're just consistent with our considered moral judgments about if it inconveniences somebody, but ultimately they are fine, even if there's an inconvenience for having to wait, it's better to take care of those who would not otherwise survive or otherwise be able to recover in such a way. So Petrini is trying to say that this principle of solidarity runs through all of our different triage practices, and it's sort of the fundamental basis for it. Summarize. So we began by talking about how there are different factors that go into triage decisions, and those introduce utilitarian and egalitarian concerns, especially as the scale of the triage event increases. It is useful to include public opinion as we're designing these triage procedures. That was what we got from Beachman Childress. And we distinguish between emergency triage and disaster triage. We also talked about the precautionary principle, how a precautionary approach errs on the side of caution because there are too many unknowns, and we revise our practices as more information becomes available. And then just lastly, we talked about the principle of solidarity that prioritizes care for the worst off. And it ultimately appears compatible with most ethical frameworks. I wanted to say a couple other things about solidarity real quick. So on pages 140 to 141, there's this discussion about solidarity. Petrini says solidarity, there we go, emphasizes a sense of togetherness that implies a commitment to provide priority to the most disadvantaged, and then goes on to talk about how significant disadvantages are prevalent within collective decision making when we make decisions based off categories, so the individual's condition are not adequately taken in. Towards the end and the conclusion, Petrini says, it would therefore be imprudent to suggest that the principle of solidarity offers a single clear-cut response, particularly in the vaccination case, insofar as a doctor privileging a relative after the accident could easily be accused of violating the principle of justice. The aim here is to point out that the principle of solidarity involves many different potential values at stake, making it necessary to avoid generalizations and to make assessments on a case-by-case basis. No matter how much we plan, the next disaster always seems to take us by surprise, to introduce a new twist, and to pervert our responses because of overwhelming, novel, and different political agendas. So the idea here is that when we operate on a principle of solidarity, it's accommodating for our pluralistic needs. And so rather than saying that there are a set of rules that will always hold, the principle of solidarity is supposed to be more pragmatic in that it can adjust or change as the context adjusts and changes.